Hi, this is Shane Hostensky in Adult Health 4. Today I'm going to be going over Module 4, Discussion Question 1, and this is in the nervous system. So today I'm going to talk about autonomic dysreflexia. Autonomic dysreflexia is a very serious ailment that occurs as an overreaction of your autonomic nervous system. Usually people who have had a type of spinal cord injury, especially an injury above the 6th thoracic vertebrae, suffer from this. The thoracic spine can be found in the middle section of the spine itself, and with the cervical vertebrae part of the spine above and the lumbar vertebrae part of the spine below. The thoracic spine begins at the base of one's neck and ends at the bottom of the ribs. The thoracic spine consists of 12 vertebrae identified T1 through T12. When the T6 vertebrae and above is injured, this can significantly increase one's chances of autonomic dysreflexia. The most noticeable sign of autonomic dysreflexia is a spike in blood pressure causing severe hypertension, along with a sudden severe headache as well. The onset of autonomic dysreflexia usually occurs anywhere between 2 to 3 months after a spinal cord injury, coming after spinal shock and neurogenic shock resolve. Episodes of autonomic dysreflexia can occur more than once, even up to 40 times per day. To get more in depth of the autonomic nervous system of a human, this is a part of one's overall nervous system and controls functions such as heart rate, blood pressure, digestion, and breathing. The autonomic nervous system can be broken down into 3 separate categories, including the sympathetic nervous system, which is our fight or flight response, the parasympathetic nervous system, which is responsible for digestion and rest, and lastly, our enteric nervous system, which controls how the body digests food. During an episode of autonomic dysreflexia, the body gets a signal of a stimulus somewhere below the damaged spinal cord. This in turn causes a reflex of the sympathetic nervous system. The body thinks it's actually in danger due to this reflex, causing vasoconstriction, or in other words, constriction of the blood vessels in the lower half of the body, which ultimately increases blood pressure. This response is normal. Human being would trigger the parasympathetic nervous system to correct the vasoconstriction with vasodilation, or in other words, blood vessels expanding. However, due to the injury, the signal cannot travel past a damaged spinal cord lesion. This is why the upper body stays in a normal state, because the spinal cord lesion, the parasympathetic nervous system kicks in, but below it does not, causing the rise in blood pressure in the lower half of the body. Roughly around 17,000 people per year in the United States have a spinal cord injury. Autonomic dysreflexia affects anywhere from 48% to 70% of people with a spinal cord injury above the T6 level. Some other symptoms people may experience apart from high blood pressure and headache are excessive sweating, bradycardia, skin flushing, cold skin, goosebumps, nausea and vomiting, blurred vision, and feelings of anxiety. Stimuli can trigger autonomic dysreflexia, such as bladder issues. An example would be a Foley catheter blocking urine from leaving the body due to a kink or a clog. Bladder testing, such as a cytoscopy or an urodynamic testing, can trigger autonomic dysreflexia as well. Types of bowel and skin issues can trigger this condition as well. Now, moving into clinical judgment, one would recognize cues by understanding the patient has suffered a spinal injury, and in particular above the T6 vertebrae of the thoracic spine. The patient's blood pressure has shot up and they are complaining of a headache. Not only that, but they are suffering from excessive sweating and their heart rate has dropped. Analyzing these cues, one would prioritize a hypothesis that this patient indeed is suffering from an episode of autonomic dysreflexia. Now it is time to generate a solution and find the trigger, which in this case, assessing the patient, one finds a Foley catheter that has been placed has a kink in it, which is causing a blockage, not allowing urine to flow out. The nurse must fix this kink and ensure it is flowing properly out of the Foley catheter, and bladder distension is eliminated. Evaluating the patient for further episodes of autonomic dysreflexia would be the evaluating outcome part, ensuring the Foley catheter is functioning properly, and if an episode triggers again, assess the bowel or skin for other possible triggers. Thank you.